Hi, I'm Dr. Felice Gersh, your integrative OBGYN physician. And this time, I'd like to talk to you about the side effects of using hormone therapy in perimenopausal and menopausal women. Well, the first thing is you need to know that by and large, the side effects are very minimal. But we first have to define what type of hormone replacement therapy or supplementation is being used, because the side effect profile, of course, is going to vary depending on what is actually being utilized. And in fact, when the old-fashioned type of hormone therapy is used, like Prempro, I have found, because I used it back in the day before I knew how bad it was, I found I had far more side effects than I have today, and for a variety of reasons. One was the product being used, the other was how it was being used. Well, let's talk about the type of side effects that are most common. And this would be across the board for any type of hormone therapy. The most common is breakthrough bleeding or some kind of bleeding problem. Now, why is that the problem? Well, if there's a uterus, and most women have a uterus, of course, some women have an endometrial ablation where the uterine lining is essentially burnt out or destroyed with radiotherapy or with thermal energy, that's heat. And in those women, they typically have no bleeding. So they're like really fun to work with because we never have to worry about bleeding. And then there are the women who obviously never have to worry about bleeding because they don't have a uterus, they had a hysterectomy. But for the rest of us who have a still functional uterus, some kind of bleeding problem is the most common problem. Whether I give the hormones cyclically or when I give it, which I don't prefer, but I do use it because some people prefer it for a variety of reasons, continuously or static. Now, both can have problems because the uterus is very particular. It has a uterine lining called the endometrium, and it grows when exposed to estrogens. So it's what is supposed to happen. In fact, if you look at the normal menstrual cycle, the first portion, the first half prior to ovulation, is called the proliferative phase. So estrogens create growth factors. Now, this is fantastic when you have it where you want it. For in the brain, you have brain-derived neurotrophic factor, you have nerve growth factor, you have growth factors that heal skin, that grow bone, that nourish all of the tissues of the body. So we need to have growth factors to grow, to replace, to repair, to rejuvenate, to maintain. And in the uterus, the growth factors will cause growth or proliferation of the uterine lining, the endometrium. So here's the thing. When we give hormones, no matter how hard we try, it's not the same as having the same exact hormones we would have going through our body if we were 21, 25 with a normal pair of healthy functioning ovaries. No matter how hard we try, it's not going to be the same. So the expression of growth factors in the uterus may be different. And when we give the progesterone, depending on how we're giving it, whether it's static or whether we're doing it cyclic, it's going to have an altered effect compared to in a normal cycle. So the uterine lining, if it grows tall enough, it will become unstable and then just fall out like a tower of blocks falling over. And if you did a uterine biopsy, which I've done many a time, it will often show what's read as, by the pathologist, dysfunctional proliferative endometrium. So it's growing, and the uterine lining is proliferating, and then it's falling out because it's unstable. So that is a problem. It's not dangerous, it's not precancerous, but it is a problem because you can't just live a good life and have random bleeding. Plus, because we have to always rule out cancer, you may end up being subjected to ultrasounds and uterine biopsies. So we really want to try to avoid having random irregular bleeding if we can. And we do try, and that's why it's so important to check levels, and we'll talk a little bit more for sure about optimization of hormones to reduce some of these side effects, okay? So what's another really common side effect, no matter what type of hormone is used, no matter what type of regimen? Breast tenderness. So the breasts are very sensitive to both estrogens and progestins, the fake progesterones, and real progesterone. So breast tenderness is a common problem. Now, one of the things that is often helpful is iodine. Most of us have an iodine somewhat insufficient diet. And where do we get iodine from? Well, the main source is from ocean fish, which most of us are not eating a lot of ocean fish. And we try not to eat a lot of ocean fish because of other pollutants that are in the ocean, particularly heavy metals like mercury, but there are microplastics. Unfortunately, our oceans are not what they used to be. They're full of different toxicants. So we usually don't encourage enormous amounts of fish eating. It should be the healthiest food on the planet, but because of the environment in the oceans, it really isn't. Well, so most of us are not getting a ton of iodine from eating the fish from the ocean. What about the plants from the ocean? Yes, they are very good sources, but how many of you are eating a very high seaweed diet or kelp diet? Well, some people eat a lot of seaweed, but most people are not. Most people I see are not eating a lot of seaweed. I actually do encourage my patients to get those organic dried seaweed squares if they like them. Or if they live in an area where they have a lot of restaurants that sell seaweed salad, and they like it, I think it's delicious to have seaweed salad as often as they can. You can also take iodine supplements. Iodine used to be very loaded in our soil because once upon a time the oceans covered most of Earth, and the plants picked up the iodine from the soil, but no more. That iodine is pretty much all depleted. So iodine insufficiency is a common problem. That's why 100 years ago they added iodine to salt, which I also recommend. I don't recommend tons of salt, but salt is actually important. Unless you have high blood pressure that's salt sensitive, having some salt in the diet is not optional. It's really required to be healthy. And you need to have enough salt in the diet. Did you know that a low salt diet can increase osteoporosis? So you want to have some salt, and especially if you don't have high blood pressure that is salt sensitive. So I recommend buying iodized salt, old-fashioned iodized salt. And that's another way of getting some iodine into the diet. What does this all go back to? The breast tenderness. Breasts are really in love with iodine. So this is really helpful. And of course, there are iodine supplements. So I'm not going to get into that more, but I just want you to know, never take more than a total of 1 milligram of an iodine supplementation in a day. That's the maximum. Okay, don't ever go over 1 milligram. There are some people out there doing massive supplementation dosing. Don't do that. Don't go there. Okay, that can be harmful. Remember my little motto, too much of a good thing is a bad thing? So let's not overdo the iodine. But sometimes that can help settle this breast tenderness that is such a common problem. Also, time will often help because especially women who haven't had any hormones for maybe 2 years, 3 years, 4 years, the breasts get kind of used to it. And it's not that it's good. People get used to things that are bad. People get addicted to things that are bad. So the breasts get used to not having the hormones, and it's sort of like an awakening, and the receptors are waking up, and they become extra sensitive. So just waiting it out for 6 months and just taking a little iodine in the diet or a little supplementation if necessary will often take care of it. And to know that it's not dangerous, that's really important. Make sure you get and your patients, if you're a doctor, get proper examinations and imaging when appropriate and so on. But just starting hormones and having breast tenderness is not a danger sign, but it can be annoying and uncomfortable. And that could be a reason why some women will stop taking hormones. So we want to make sure we can work through that, right? So those are really most common ones that are seen, and certainly what I see. Now, what are some others? Well, if you're using a synthetic progestogen, that is a progestin that's fake progesterone, okay? Well, some of them can actually increase acne or facial hair. So that's a side effect nobody wants to have. Nobody wants to use hormones and get acne or facial hair. I have not seen that with bioidentical progesterone. I have never seen. I'm not saying it can't happen, but I personally, in many, many, many years, have not seen women getting acne and facial hair. But it's reported as a side effect, predominantly from the synthetic fake ones, okay, the progestins. Now, anytime you take something orally, and many people are taking hormones orally. Now, I am not in favor of that, but oral hormones are used. So I want to cover the gamut here. People can have nausea. So nausea and GI symptoms. So what kind of GI symptoms? Well, estrogens tend to be more constipating and progesterone more motility activating, so more potential for diarrhea. So a woman who goes on hormones, possibly, I almost never see this, but sometimes it happens that a woman could have diarrhea or constipation or alternate because of her GI motility sensitivity. So that can happen, but it's uncommon. Often that will go away with time, but you have to look at the doses and look at the regimen and then see how it goes. So sometimes women who had problems with their GI tract when they were having normal menstrual cycles, especially during the luteal phase, which is when they could get PMS, they might have such things as GI problems. Also, bloating can happen. Now, I mentioned the luteal phase. There's a certain small subset of women, when given bioidentical progesterone, particularly when it's taken orally, they get what's called a paradoxical reaction. In other words, progesterone normally is calming. It's like it reduces anxiety, it reduces depression, it promotes sedation, like it's calming, it's like muscle relaxing, and it just tends to be very nice for a lot of women, but not some. It's the opposite effect. In fact, this is what a lot of the theory now is for PMS, premenstrual syndrome, and the more severe version, PMDD, dysphoric disorder. That's an actual psychiatric condition, premenstrual dysphoric disorder, PMDD. That it's related to a paradoxical, like an opposite effect of what is normal to progesterone. Well, this can happen in nature, naturally, in a menstrual cycle, and that is producing PMS, but it can also happen when you give even bioidentical progesterone. As I mentioned, it tends to be more severe if you give the progesterone orally, but even if you give it vaginally, as I'm using much more now, it also can happen because still a lot of progesterone is converted into allopregnanolone, and allopregnanolone is naturally an antidepressant, it's anti-anxiety, it's sedating, calming, it's neuroprotective when you have the right amount, but in the paradoxical people, it actually causes agitation, insomnia, irritability. So I do occasionally have patients who feel this way when I give them their hormone therapy. They feel really agitated and upset, and they feel irritable, like they're going to explode, and they cannot sleep. That group doesn't tolerate progesterone. And what I do for them, because we try it orally. No, that's not going to work. Vaginally, some of them will tolerate it and do okay vaginally. They can't take it orally, because when you take progesterone orally, 80 to 90% is converted into other products called metabolites by the liver. The majority is allopregnanolone, which is probably what causes the paradoxical effect. And when we give it vaginally, you're not going to have that big conversion through what we call the first pass through the liver. But there's still some that even when given vaginally or topically as a cream, which I will use sometimes, they still get that paradoxical effect. For those, I just can't give progesterone in the bioidentical. So what I do is I give a synthetic progestin, the most agreeable one, which is norethindrone, for 2 weeks every 3, even up to 6 months apart. So we just do a withdrawal bleed every few months and check ultrasounds to make sure the uterine lining is not getting too thick, and just monitor. If I have to, I do a uterine biopsy, and we avoid progesterone for that group. So that's unfortunate, but it does happen. Now, what about other problems? Well, skin irritation. I mentioned if you take any product orally, you might get nausea, you might get GI upset. Stuff like that happens. Well, what if you put something on the skin? Well, somebody's going to be allergic to whatever it is that's carrying the estrogen in it, whether it's a patch or a cream or a gel. I've had some patients get rashes, get hives, just get itching. So sometimes we work with compounding pharmacies and they get much more non-allergic, irritating types of creams. They'll use a variety of different types of creams. They'll send the patients different creams without hormones in them just to try out on their skin, like a little testing site. Some women, about 5% who use the patch, will get a patch rash. So you can treat that with a little hydrocortisone cream, a little steroid cream, but you don't want to do that forever. So if it's very infrequent or very minimal, you could do that. But otherwise, the best solution is to not use a patch, since we also have other options like creams and gels. So, but remember, you can use a cream or a gel and also get a rash, because some people will be allergic. So sometimes we have to go through a variety of different products. There is also a vaginal ring that has 2 different doses. I don't use it too often, but it is available, and for some people, that could be the solution. If everything that's put on the skin, they get a reaction to. Of course, when you put things in the vagina, you might get an irritation there. And that could be from the ring, or when I'm more and more using the vaginal progesterone placement. Occasionally, I've had people say it caused vaginal irritation. So no matter what you do, wherever you put something, there's that one in the crowd that will get an irritation from it. What else? Well, headaches. And whenever we do a study with anything, even the group that's called the placebo arm, the people who get virtually nothing, there's always a small percentage that get a headache. So headaches can happen, whether it's due to the hormones or stress. It's hard to say sometimes, but that is a known potential side effect from hormone therapy, could be headaches. Now, headaches like migraines tend to occur when you have a drop in estrogen level. So you got to watch, what are you doing? So a headache could be triggered if you're using, say, a patch, because the patch may not deliver. In fact, I know it doesn't deliver the same amount of estrogen day 1, 2, 3, the third and a half day of the patch. So dropping levels of estrogen can cause a migraine or a headache. So in that case, if someone is on hormone therapy and they're getting a lot of headaches, probably don't use the patch. Try something that is going to get a more stable level, like either the gels or using compounded creams where you can apply it twice a day, even more frequently, to maintain the level. And what you don't want to do is give days off you don't want to give days off. I come across some patients who have seen other doctors and they tell them take 1 or 2 days off of using estrogen every week. There's no rationale for that, okay? So nobody goes from here to zero, okay? And just not having hormones for 1 or 2 days a week is not rational, okay? So don't do that. But that can trigger a headache, so we don't want that for sure. Now, what about moods? Well, moods can be hormone related, so you never know. Hormones can go up and down and swings and how they're absorbed and how they're working in the body. So some people can have mood swings. Some people can say it makes their sleep more interrupted. The majority say it levels out their moods. They feel so much better. They feel happier. They sleep so much better. But there's always that 1 or 2 in the crowd that say their sleep is worse. Their moods are upset and, more disordered. They're having fluctuating moods and so on. And that could be because their hormone levels are fluctuating, that they're not really, or they're getting an inadequate dose. So you got to measure the levels. You got to reevaluate, change the routine. I find that my patients who are the majority, who are on cyclic hormones, are doing the best. It's more physiologic. I think expecting someone to have a static dose of estrogen and progesterone every single day, it changes how the receptors work. It changes how the body works. It's not really physiologic, not even at all. Usually the doses are much too small. So I find that using the physiologic dosing with the biological rhythms, with using the cyclic nature of the hormones, I get by far the fewest symptoms. I get much less breakthrough bleeding. I usually don't have any. We just sometimes have to work to get the right levels in the beginning, but then it's usually smooth sailing, whereas when you're using continuous static dosing, you get more just random bleeding. So I get less bleeding. I find I have better moods in my patients. They have fewer headaches, but sometimes I'm using the patch and I do get headaches because of the difference in the absorption over the course of the patch. Like I said, don't see headaches very often that way, and I don't see acne. I don't see facial hair. I don't really see a lot of GI problems, but they're known as a side effect, and if I had it, I would look at the ratio in terms of how much progesterone am I giving, how much estrogen. I don't mean an exact number ratio, but looking at how they're doing and check the levels, making sure they're in the physiologic range. So checking levels is not the standard of care, because the standard of care is not to give hormones for optimizing health. It's for certain symptoms like night sweats and hot flashes. But if you're sort of an outlier like I am and many more, and we're trying to give hormones for optimization of health, we know this is off-label, then I really believe that looking at levels matter, because this is something that I have found so prevalent. A patient goes and fills a new prescription, say for the estrogen patch, and they get a different manufacturer of the patch. And this manufacturer the patch doesn't work for the patient. So suddenly the levels are plummeting. And of course they start having breakthrough bleeding. They're not sleeping well. They may even have recurrence of night sweats and hot flashes. Things are not right. And it seems like it's a side effect of the hormone treatment. What it is, it's a new manufacturer of the patch, and this one is not absorbing for the patient, not getting the estrogen into the body. So these are the things that I have to always look at. You have to be like a real medical detective when patients start having symptoms. Is it the product? Maybe it's a change of manufacturer. Maybe they just got a different batch that sat out in the sun or in a hot truck somewhere or something, and it really disabled the product from really working properly. So we got to look at all these different things to see what might be underlying the problem. So as you can see, none of the things I suggested or mentioned as side effects and issues are dangerous. They're not dangerous, they're annoyances. What about the ones that people are the most afraid of? They talk about like blood clots and like having a heart attack or a stroke. We're not dealing with breast cancer here. We're not talking about that, but just these other issues. I want to make it really clear. There's a lot of data that shows that transdermal estradiol, now not oral, transdermal, does not increase the production of liver clotting factors, does not increase inflammation, does not increase your risk of a blood clot. It's the same, maybe even less in my opinion, but for sure it's the same as if you were not on hormones, okay? It's not an increased risk of blood clots. And what about having other issues like a heart attack or stroke? No, not when you're using the bioidentical transdermal estradiol. It does not increase heart attacks. It does not increase strokes. In fact, there were published reports way back that women who were in the middle of a heart attack, if they got an IV infusion of estrogen, it actually helped reduce their risk of a bad prognosis. It improved their outcome. So and I have not seen that. Now, recognize though, that going on hormones doesn't mean you can't have anything. It can change the risk, it can lower the risk, but it's not going to eliminate the risk. So any woman on bioidentical hormone still could get breast cancer. I said, I'm not going to talk about it, just that one thing. It doesn't increase the risk, but it doesn't mean you have no risk. It doesn't mean you can't get a heart attack or a stroke, or you can't get a pulmonary embolism or a blood clot. It doesn't mean you can't get those things, but it's not increasing the risk, but it's not eliminating all the risk. So I love hormones, as you know, and the side effect profile is very manageable. Like I said, breast tenderness and irregular bleeding, or breakthrough bleeding, are the most common side effects, and the others need to be individually managed. They all need to be individually managed. All are not dangerous, and all can be dealt with. So don't go into using hormones with a lot of fear. And the side effects are very reasonable and can be well worked with to make the right dose and the right everything work for you so that you can live with hormones for your rest of your life.